So this is weird. Welcome to liver pathology on Wednesday morning at 8 a.m. in New York City. We're going to do 4 cases today that I sent around to the local residents. They've all had a chance, I think. You've all had a chance to look at them. There are 2 sessions we're doing. When is the second one?
We have to set it up next month sometime.
Okay, it'll be next month sometime. We haven't set that up yet. But now that you're connected by Twitter, we'll be able to send out information about that. That's going to be what I would consider somewhat more interesting cases, things that are going to be important for you in daily practice in coming years, but a little bit more complex. Today we're actually going to do basically 2 topics. One is perhaps the most important one in the coming years. 50% probably for most of us, our liver biopsies will be fatty liver disease. So I'm just going to go over the basics of fatty liver disease and how I write those diagnoses and how I look at a slide, just my approach to that. And then a special case that is not often discussed in the literature, but I find a common and very important clinical problem. So we've got these 2 topics to look at. So 4 slides. So welcome, and let's go to case 1. Oh, is it me now? Okay. I just...
Yeah.
Is the camera in focus?
Yep.
Okay. How do I turn the light up on this? This? No, that has to... Okay. Is that okay for the camera?
Yep.
Okay. So we see that there's some fat here. Okay. But what was the clinical history on this case? This is... Oh, does someone... Yeah?
So it's a 56-year-old man with a history of NASH and elevated LFTs.
Okay, so this is a kind of typical clinical history that one gets. Which means a paucity of information. It could be worse. It could simply say elevated LFTs. Well, of course. Why else would we be doing a biopsy? You know. But this one they actually say history of NASH. So what does NASH stand for? Non-alcoholic steatohepatitis. So that's a clinical word indicating that the patient has what general systemic medical condition?
Obesity?
Well, obesity is part of it.
Autoimmune disease?
No, not autoimmune disease. Metabolic syndrome. Okay, so how do we define metabolic syndrome? What are the clinical features that say that a person has metabolic syndrome? The major features. There's some minor ones, but hypertension. So we think obesity is the first thing that comes up, and obesity is one of them, but also hypertension,
hypercholesterol, maybe pre-diabetic.
So dyslipidemias of some kind, high cholesterol, high triglycerides.
Waist size?
Well, that's obesity. What's the 4th thing?
Pre-diabetic, diabetes.
Yeah, so some sort of glucose metabolic problem, either pre-diabetic, insulin resistance to some degree. And insulin resistance is really considered the fundamental problem in metabolic syndrome. And this is a multi-organ disease, so it's going to be affecting other organs. Obviously, cardiovascular disease runs with this pack in a major way, just as liver disease does. So they're telling us the patient has metabolic syndrome. They're telling us the patient is not a drinker. So this is a problem for the pathologist, because how often do our clinicians, if they have a patient who is obviously with metabolic syndrome, how often do they dig for the history of alcohol? Probably not too often. Before, 30 years ago, before we had an epidemic of metabolic syndrome and non-alcoholic fatty liver disease, the predominant fatty liver disease we'd see was alcohol. And the clinicians back in those days, when I was in training, would routinely be very aggressive in investigating the possibility of alcohol use, speaking not only with the patient, but with family members, with friends, and really digging to see whether there was denial of an actual significant alcohol use. That's uncomfortable work to do from a clinician's standpoint. And if a patient actually comes in with metabolic syndrome, they may be disinclined to pursue that. So we can take them at face value that this patient has metabolic syndrome, but that does not mean the patient is not drinking. So that conditions to some extent how we'll write our diagnosis on this case, which we'll eventually get to if I ever show you the slide and stop talking. What else about NASH? So the clinicians use the word NASH, non-alcoholic steatohepatitis, and that is their clinical syndrome of having metabolic syndrome and having elevated serum transaminase levels. So that's the elevated LFTs they're referring to. And so from the clinical standpoint, they can call this NASH. But pathologists, and to some extent hepatologists who have a more subtle understanding, don't call it NASH. They call it what?
NAFL.
NAFLD, which stands for?
Non-alcoholic liver disease.
Right, non-alcoholic fatty liver disease. So as pathologists, I encourage you to think about that. And the reason is there are 3 histologic categories of injury or change in the liver that we observe in non-alcoholic fatty liver disease. What are those 3 things? Number 1, the most obvious. Fatty liver. So steatosis, fatty change in hepatocytes. What's the second thing? Histologic feature. More broadly, steatohepatitis, the kind of hepatocyte injury and inflammation that you see in fatty liver disease, which we'll discuss in a moment. And the third thing, right, fibrosis, what we call steatofibrosis, because it's a specific pattern of scarring that's different from autoimmune liver disease, biliary tract disease. It's different than viral hepatitis. It's its own special pattern. So we look for 3 things: steatosis, steatohepatitis, and steatofibrosis. And so if we say the patient clinically has steatohepatitis, non-alcoholic steatohepatitis, NASH, and then we say histologically the patient doesn't have any in the biopsy, is someone wrong here? No, because the clinical syndrome of NASH may pertain even though there's no histologic steatohepatitis. So for pathologists, I prefer to use the term NAFLD for the disease category and to restrict the use of steatohepatitis for the histologic features one may see in fatty liver disease. Okay? Any questions about that? So those are the 3 things when I have a biopsy that comes to me labeled fatty liver disease, or if I look under the microscope and see fatty liver disease, these are the 3 things that I know I need to assess in every liver biopsy. So when you come in, you have a clinical history that tells you fatty liver disease, or you look at the slide blind without the clinical history, or they merely do not supply you with the clinical history, which is very common, and you see fat, then you know you're in the category of fatty liver disease, and then you have to evaluate steatosis, steatohepatitis, and steatofibrosis. And you have to mention all 3 of those things in your diagnosis. Otherwise, your diagnosis is incomplete. Okay? So now we're ready to look at the slide. And what we have is, going along with the history, there is a little bit of fatty change. So even though I see other things, there are other abnormalities in the biopsy that a bunch of you in the room and also outside.
We can't hear you at BI.
You can't hear me?
No?
Can you hear me now?
Yeah, now we can.
Okay.
Thanks.
Thank you. You should have spoken up earlier. Can we find out if the Twitter people can hear me? Can they?
They are.
They are? Okay, we'll just assume. So you may be seeing other things in the biopsy already. You can see that there's some inflammation here, and you probably are noticing that there's some scarring. But I'm ignoring those for now because I want to look at those 3 things systematically. And so the first thing I'm assessing is there fat in the biopsy? And there is. But notice I have to look around for it. Some areas have a fair amount of fat. Bless you. And some areas have very little fat. Does that mean it's not fatty liver disease? No, because you still may see other features. There are situations where you can see steatohepatitis and steatofibrosis and not see a lot of fat. And we have the clinical history. Now, normally in my routine practice, I do not look at the clinical history before I look at the slide. So I would look at this, and it isn't screaming to me fatty liver disease, but there is some fat, and I would have to consider fat. But in this case, we did look. So there's fat, and I would label it, I think mild, moderate versus severe. Severe to me is the entire lobule is involved by steatosis. So if you think in a non-fibrotic liver, you have where does fat? Okay, this is the rule of threes for fatty liver disease. There are three things you have to look for: steatosis, steatohepatitis, steatofibrosis. Where does the fat start to accumulate in a liver that's becoming fatty?
Portal triad?
No, not the portal triad.
Zone 3.
Zone 3, acinar zone 3, or the pericentral region, around the central vein. And then as it gets more severe, it extends from the central vein out towards zone 2, and then eventually reaching the portal tract. So in a fairly non-scarred liver, you can call it mild, moderate, or severe just by talking about, is it confined to acinar zone 3, the pericentral region? Is it extending halfway or 2/3 of the way to the portal tract, or is it filling the lobule?
I have a question.
Yes.
Often most of the textbooks record this grading of the degree of steatosis, like less than 5%, 5 to 10%, below 33%, more 33 to 66%. It looks so weird. I mean, how does somebody even know that when it's 65% and when it's 67%?
Well, okay, number one, who cares? That's why I'm not so precise with these things. From a clinical standpoint, it really doesn't matter. The bigger issue with that kind of grading of steatosis is that, are we talking about a linear scale from the central vein to the portal tract, in which case it's 1/3 is the mid-lobule, 2/3, is the central lobular region, 2/3 is the mid-lobule, 3/3 is all the way to the portal tract. So that's a linear scale. Or do we mean cross-sectional area that we're seeing in the biopsy? Or do we mean an actual volumetric assessment? The only time this percentage is important, is truly clinically relevant, is when you are looking at donor organs for use in transplant. Because hepatocytes that are expanded by macrovesicular steatosis are unstable in the cold ischemic period as the organ is going from the donor to the recipient, and those will necrose. And so if you have too much fat, the liver dies on entry. But that's not the topic here. And so I don't want to go into that in detail. But for just assessing fatty liver disease, it really doesn't matter. But this brings up the issue of the grading and staging schemes that are out there, in particular Beth Brunn's original scheme, and then the subsequent development based on that of the Kleiner scheme that Beth was involved with. And if you look at those papers, the purpose of those grading and staging schemes was very clear. They were aids to research. If you're doing clinical trials particularly, and you're studying large populations of patients, you need a way to record all the data. And you need a way to analyze the data statistically. So you have to turn it into categories and numbers that you can make comparisons between. And they are very clear that that's the reason they are developing these schemes. And they are very clear in the papers that these were not intended for clinical use. Now, they are a good way to fully describe what's in a biopsy, so you may be tempted to do that. My issue with grading and staging schemes, though, is, as we've seen with all the schemes over the years with chronic viral hepatitis, number one, soon you have 2 or 3 schemes, and the numbers from one versus another may actually be different. But that subtlety is often lost on people. So there's confusion because pathologists are not reporting, they're just saying grade 2, stage 4, but they're not saying, oh, grade 2, stage 4 in a particular scheme. So that leads to confusion. Worse yet, the clinicians tend to expect numbers. And so when you give them the stage is cirrhosis, and they say, but what's the stage of disease? Well, the stage is cirrhosis. Yeah, but is it a 2 or a 4? They've clearly lost the understanding of what the disease process is, and they've gone into this automatic mode of just give me a number so I can plug it into my concept. And I think that's something not to encourage clinicians with. But it's difficult because, you know, our work comes from the clinicians, and that's who we're working with. So the major take-home point is, if you're looking at liver biopsies, you should be talking to your hepatologist. Ultimately, they are our clients for what we do as a job, and so you need to work out with them what information they need to know. But at this point, I am not using any official grading and staging scheme for fatty liver disease because I'm not doing clinical trials, I'm not comparing specimens between patients, and I don't want to encourage the clinicians to lose sight of what the actual disease process looks like. Because at the moment, they still know. 5 years from now of using grading and staging schemes and just getting numbers, they will forget. So maybe we'll get through one case today. The rest will go quicker because I'm dumping everything now. So mild, moderate, or severe steatosis. Does it matter in terms of clinical practice what's going to happen to the patient if they have mild steatosis, moderate, or severe? Not really. All it requires is there fat there? Can we confirm that this is the category of disease we're in? And yes, we can. Okay? Now, one other thing, digression, that's important to get out of the way. The most common thing I read in reports from outside when I get consult cases describing fatty liver disease, they say mixed micro and macrovesicular steatosis. And I really feel that the reason that is written over and over and over again is because it's a lot of words, and a lot of pathologists who are not comfortable with liver like having a phrase that they can throw in that makes them feel like, okay, I know something. Steatosis in fatty liver disease is always mixed micro and macrovesicular because small droplets become mediate droplets, become large droplets. So there's always that spectrum. There's no point in saying that. The only time we need to specify micro versus macro is when every hepatocyte virtually has microvesicular steatosis, small droplet fat. And when you have that condition, that is not fatty liver disease as in alcohol or in metabolic syndrome. That's usually mitochondrial injury, often from a toxin. You're talking Rise syndrome, fatty liver of pregnancy, which is not a toxin-related thing, but fatty liver of pregnancy, tetracycline, valproate toxicity, and my favorite disease, vomiting sickness of Jamaica from eating the unripened fruit of the yaki tree, because I love saying that. Those are all acutely severe injuries with mitochondrial dysfunction, and they're often patients who are very cholestatic and will need a liver transplant or they're going to die, which is obviously a very different situation. So the only time you need to say micro versus macro is when you see that, and then you say diffuse microvesicular steatosis, compatible with or suggestive of. When it's just fatty liver disease, you're not adding anything to the report. It's always mixed micro and macrovesicular steatosis.
So just say steatosis, that's it.
So I just say steatosis. And in this case, it's mild. If I'm sitting with a resident who said it's moderate, on this case I'd go, really? You think this is moderate? I'll show you moderate and pick up another case. This looks mild to me. But often a resident will be sitting with me and go, really? That's mild? I thought it was moderate. And I'll go, okay, it's moderate. Because it ultimately doesn't matter. The question is really, is it there or not? If we were doing a study, we might want to know how much. But at this point, there's no clinical relevance to the amount other than to confirm that we're in the realm of fatty liver disease. So, the next thing I look at, so this has mild steatosis. The next thing I look for is steatohepatitis. And the classic forms of steatohepatitis are hepatocyte ballooning with Mallory-Dank bodies. So here's another digression. We used to call them Mallory bodies. Now we call them Mallory-Dank bodies because Helmut Denk in Austria, in Graz, did a tremendous amount of work studying the intermediate filaments that create them and the lesions themselves. And in his honor, the group of people in the world who are interested in Mallory bodies renamed them Mallory-Denk bodies. So we now call them Mallory-Denk bodies, D-E-N-K. So if you're still saying Mallory body, please remember Professor Denk in Graz. Mallory-Denk bodies. So, hepatocyte ballooning, often with Mallory-Denk bodies, or neutrophilic infiltration. It's one of the few times we see neutrophils in the liver. In almost every other organ, you see neutrophils, you say acute injury, you see mononuclear cells, you say chronic injury. That's not the case in the liver. In acute viral hepatitis, it's mononuclear cells. In chronic viral hepatitis, it's mononuclear cells. In chronic fatty liver disease, it's still neutrophils. So neutrophils, it has to do with cytokine signaling and the things that are the causative agents for the injuries, etc. So if you see neutrophils, that goes along with steatohepatitis. It's more typical in alcohol to see neutrophil-rich infiltrates than it is in non-alcoholic fatty liver disease, but you can see it in both.
So when you see lymphocytes in a lobule, like in a case of steatosis, so then you do not call it a component of steatohepatitis, right?
Well, it's not really clear. We're sort of in a transition zone. So, for example, I blew by this portal tract. This has some mononuclear cells. It also has fat.
Mm-hmm.
This fat is probably in macrophages. This is probably like an inflamed lipogranuloma. So there was probably more fat in this liver before. It was released and got taken up by macrophages that are carrying it out through the portal tract here. But there's inflammation. The more we saw fatty liver disease, non-alcoholic fatty liver disease over the last 25 years, the more we started to realize this does not mean that there is concomitant viral infection. 20 years ago, I would actually say that. I would see this kind of portal inflammation and say, oh, there's a mild mononuclear infiltrate, cannot exclude concomitant hepatitis C or B, for example. And none of those cases ever turned out to be viral positive. And what we started to realize is, no, there is a mononuclear component to non-alcoholic fatty liver disease too. And in alcohol, if you look for it carefully. But it's still not officially, it's not such a hard criteria that we can say that's steatohepatitis. So what I want to see is the ballooning, with or without Mallory-Denk bodies. And to find it in non-alcoholic fatty liver disease, it's often very mild, and you have to really look around. And so I go to higher power after doing the assessment at low power for, is that your phone or my phone? Oh, let me turn this sound off. Twitter is going crazy. And so here, I think, in this area with more fat, we also have some steatohepatitis. So there's cells becoming more white because they have big lipid droplets. But there are cells becoming more white because the cell has ballooned and swollen with fluid. Presumably there's injury to the cell membrane, fluid flows into the cell up the osmotic gradient, and you wind up with ballooning. And these little stringy things are Mallory-Denk bodies. Now you can prove they're Mallory-Denk bodies by doing a CAM 5.2 stain, keratin 8 and 18. Because one of the things Helmut Denk showed is that while hepatocytes normally have cytoplasmic keratin 8 and 18, particularly strong in the perinuclear and submembranous areas, in cells that are ballooned, that keratin 8 and 18 collapses down into the Mallory-Denk body. It becomes a ghost cell, negative for the keratins, but in the Mallory-Denk bodies, they're all concentrated. So you can use that if you're thinking, is this or is it not? You can use this. So for a case like this, I'll say steatohepatitis, mild focal. And most cases are mild focal. You have to really look around. There's an occasional acidophil body. Why this cell has died through an apoptotic pathway, I don't know. It's one of the questions in the field. But notice you can still see lipid inside of it. This was a fatty hepatocyte. So that's not officially a form of steatohepatitis, but I'll lump it in there. Once I've seen the other typical form, I'll lump this in there. And the portal infiltrate. So if I want to describe it, I will do so. Oh, here's some more ballooning. And here's some more prominent malaric deck material.
So I have a question. Like in this field, for example, like often we have this confusion that okay, whenever we see rarefied hepatocytes in a case of fatty liver disease, we tend to think that oh, these are all balloon hepatocytes. This is not right. Say for example, in this field there are so many hepatocytes which look more like open
Like
chromatic,
these.
open cytoplasm,
Yeah.
foamy, etc.
You know, a lot of
Those
this
are
is
not
also, a lot of it is also glycogen. So if you really were worried about it, you do a PS stain and they'd probably be glycogen rich. Or it's microvesicular fat, and the biopsy isn't small droplet fat, and the biopsy isn't so well fixed, and so that sort of disintegrates. It's hard to see. What you really need to see is an oil red O stain, but we're not going to do that because that requires frozen tissue. So, but I don't get hung up on this. Its presence is what's important. If there's a huge amount of it, I'm going to get a little more aggressive about suggesting that alcohol could also be responsible, because non-alcoholic fatty liver disease usually, not always, but usually doesn't have very prominent ballooning and very prominent malaric deck bodies. You usually have to search for it like this. On occasion you see cases where it's much more extravagant, but where all these things are more extravagant, I'll tell the clinician, not in the report, because there are social and medical legal consequences to putting alcohol in a report. But I'll tell the clinician personally, hey, really make sure you're excluding alcohol in this case. So that begins to give an idea of how I write my reports. My diagnostic line for this kind of case is features of fatty liver disease, comma, question mark, alcoholic versus non-alcoholic, comma, with, and then I'll list the degree of steatosis, steatohepatitis, steatofibrosis. I always say alcoholic versus non-alcoholic, because unless I have a clear, really concrete clinical history, I can't be sure. And I have been fooled on biopsies where I thought, this certainly is a patient who was drinking. And it wasn't. It was a patient who was diabetic. But in this patient, for some reason, the changes of steatohepatitis were so extravagant. It smelled to me like alcohol, but it wasn't. Flip side, you just can't distinguish them. And you can't be sure you have the complete clinical history. So leave it in the clinician's hand. It's not your job to decide the underlying cause of the fatty liver disease. If you have a suspicion, communicate with the clinician directly. But in the report, nearly always, question mark, alcoholic versus non-alcoholic. Okay? So there's a little bit of steatofibrosis, steatohepatitis. And now, I don't bother assessing on the H&E, the fibrosis, because on H&E, in viral hepatitis, the fibrosis is really clear on H&E. The trichrome will help, but you usually see it. But because of the nature of steatofibrosis, often thin tendrils of collagen starting around the central vein. So again, the steatosis starts around the central vein, the steatohepatitis starts around the central vein, the scarring starts around the central vein and extends outwards, reaching for the portal tracts. Where it starts, it's perisinusoidal or pericellular fibrosis, thin tendrils of collagen around individual or small clusters of hepatocytes. To see that on an H&E, I see a lot of these cases and I do not trust myself to be able to see it. So for steatofibrosis, I don't even try to get an idea of it from the H&E. I just go right to the trichrome. Now, our trichromes at this institution are not always great. This one seems not too bad. And what some of you may have already guessed by tooling around the H&E at low power is it seems that we have nodules developing. We certainly have fibroception. So there's an abundance of scarring here. I think we're probably in a transition to cirrhosis. Here, this area looks clearly cirrhotic. This area, not so clearly cirrhotic. So to me, that's what I call transition disorders. And again, there are formal grading and staging schemes that will tell you how to describe this. Those, according to their authors, are for research. So I will simply describe this as best as I can. Now, what are the features of steatofibrosis?
Pericellular fibrosis or perisinusoidal fibrosis.
Yeah, starting around the central vein. And so here, for example, is a central vein. And look how it's linked up to a portal tract, and they've been drawn together. So central portal linking fibrosis is the pattern of scarring of steatofibrosis. Viral hepatitis, what's the pattern? What structures are generally linked in viral hepatitis? Portal to portal tract. In primary biliary cirrhosis, we now call it primary biliary cholangitis, sorry. What gets linked together? Same thing, portal to portal. Chronic biliary tract disease in general, portal to portal. Fatty liver disease, alcoholic or non-alcoholic, is central to portal. So central portal linking, or central portal fibrosis, is one of the features of steatofibrosis. Here's some pericellular fibrosis, nicely shown. See how you've got collagen fibers weaving in and around hepatocytes. And you can see these fibers would be very difficult to see on H&E. But on trichrome, they leap out at you. So for this biopsy, features of fatty liver, compatible with fatty liver disease, question mark, alcoholic versus non-alcoholic, even though they said NASH. I don't know. I'm relying on their clinical information. I'd rather just keep it neutral. Question mark, alcoholic versus non-alcoholic fatty liver disease with colon, and then I do 1, 2, 3. 1, steatosis, mild. 2, steatohepatitis, mild confocal. 3, steatofibrosis, transition to cirrhosis. And that's my report. And that gives them all the information they need. And of all of these things, what's the most important thing that they need to know, besides confirmation of the disease process? The amount of fibrosis. And at the moment, that's important to give prognostic information. Because right now, we don't have treatments that work. When we do have treatments for work, this may go the way of hepatitis C. Up until almost a year ago, we had to know how much scarring there was in a hepatitis C liver, because that would help determine whether a patient should be treated or not. Because the treatments were harsh, they weren't very good, and so you wouldn't want to treat someone who didn't need it. That information was important. Now, everyone who gets hepatitis C gets treated, and we have curative treatments. So it doesn't matter what the stage of disease is. They're all going to get treated. So now we suddenly don't see biopsies for hepatitis C anymore. That's why fatty liver disease is going to be 50% of your practice, because the 90% that was hepatitis C has dropped out. One day fatty liver disease may be the same way, but it is not yet. So right now, is this a patient who with their fatty liver disease is scarring or not, is important prognostic information. Are they actually already cirrhotic? That's important prognostic information for the patient to know.
So there is one thing, there is one feature which was quite obvious in this biopsy, was that though the progression has already been there to cirrhosis, and we see that actually steatosis is so minimal. So is it a feature of fatty liver disease that when there is progression of the disease to cirrhosis, so you see less activity, you see less of steatosis and less of steatosis, steatohepatitis as it has already become cirrhotic?
No. Yes, but no. What you're suggesting is that as scarring goes up, fat goes down. And that's not true. Mm-hmm. What is true is that in established cirrhosis, there is often no fat. We don't know why. And so most cases of what used to be called cryptogenic cirrhosis in the United States, we've discovered, looking at more detail at their clinical histories, now that we know about fatty liver disease, 90% or so of cryptogenic cirrhosis, unexpected cirrhosis without a clinical history, turns out to be non-alcoholic fatty liver disease. And those livers often don't have fat, which is why people back in the day didn't think they were fatty liver disease. But now we know that that's the case. So when you have an established cirrhosis, the fat may go away. We don't know why that happens. Lots of theories, but we don't know why. Otherwise, the relative amounts of fat and steatohepatitis and scarring in the livers are independent of each other. You can find any combination. So let's say you have no fat in a biopsy, but lots of ballooned hepatocytes with Mallory-Dank bodies, and let's say a little zone 3 pericellular fibrosis. You've got fatty liver disease, you've got zone 3 pericellular fibrosis, you've got steatohepatitis, you've got ballooning and Mallory-Dank bodies, but no fat. What's a clinical situation where that could happen? An alcoholic who stopped drinking, a diabetic who finally got their diabetes under really good tight control. The fat will disappear very fast. Mallory-Dank bodies and ballooning takes about 6 months to disappear. So you can imagine situations where you have fatty liver disease but no fat. So these things can happen in any combination.
The terms perisinusoidal and pericellular are the same, or is there any?
People use them interchangeably. I mean, it's not that important. The collagen fibers are often depositing early on in the space of dissus, so that is perisinusoidal. But it's also pericellular, because on one side it's sinusoidal, but on the other side it's the cell. So people use both terms. I don't think it's important. But when you see it, that's what's important. So let's go to another case. Case 2. Is someone officially assigned to? Yes. So tell me about it.
So,
And the reason we're going for the history first is, rather than looking at the slide blind, is because I'm telling you, we're doing fatty liver disease this morning. So that's the topic. If this were coming as a clinical case, I would not look at the clinical history first. But go ahead.
So yeah, we have a 34-year-old man with elevated liver enzymes, MS, psoriasis, and no history of methotrexate
Yeah.
use.
So they didn't give me the methotrexate use initially in the clinical history. They just said psoriasis. I immediately called the clinician to ask about methotrexate, because a reason for getting liver biopsies in people with psoriasis is that they're being treated for methotrexate, and you're looking for methotrexate toxicity, which might prevent them from receiving methotrexate. So that's often the reason for the biopsy. So I called the clinician and I said, is this a methotrexate toxicity biopsy? And he said, no, the patient doesn't take methotrexate. But the reason this is an issue is methotrexate looks very much like fatty liver disease. Particularly end stage, late stage methotrexate looks like non-alcoholic fatty liver disease cirrhosis. So they are related. You know, methotrexate is one of the drugs that can, like alcohol, that can cause fatty liver disease. So that's a whole separate topic.
So that means before we start the slides, we know that if there is any fatty liver disease in this case, so it's not because of methotrexate.
Right, exactly.
Yeah.
And if there is methotrexate on board, that is probably the reason for the biopsy. And there is a methotrexate grading, staging scheme that is used that you need to look up. And by and large, the liver pathologists who know this work in places that have big, robust dermatology programs where they're seeing a lot of patients with psoriasis. So when I was at NYU, this was a common biopsy. At Beth Israel, it is not a common biopsy. So it all depends on where you are. But that's not the issue in this patient. Oops. We just lost light. Oops. Oh, you rolled over the power, I think. Okay. Don't do that. So this is a more typical fatty liver disease biopsy. I probably should have left the advanced stage one, the developing cirrhosis one, till later. So you see that there's fat, and it's in a clear zonal distribution. At low power, you can see the fat is in the central area, and the portal tracts don't have fat around them. So what you're really seeing is acinous zone 3 highlighted by steatosis. It's very nice.
Can we call this moderate?
Well, there you go. That's the question. Can you call it moderate? Yes. Can you call it mild? You might. Can you call it mild to moderate? Sure. Does it matter? Not really. You have to call it something because the clinicians won't be happy if you don't say how much. But don't go crazy sweating over, well, is it 32% versus 36%? It's not relevant. Do I need to know why you're whispering over here?
No,
Can you do the restart?
it's fine.
Oh, this is fine. Okay, cool. So again, here's the central zone, and there's the central vein. And there's fat around it, and the fat spreads out, approaching the portal tract. There you go. And it's about halfway there, so maybe I'd call this moderate. Or mild to moderate. It depends on my mood, and it depends on the resident I'm sitting with. So that's one. There's mild to moderate steatosis. Steatohepatitis. So for that, I go to high power. Oops. And I look around. I don't see a neutrophilic infiltrate, and that's pretty much the least common thing. And I'm really not seeing any steatohepatitis. So steatohepatitis, absent. And then I go to the trichrome to look for steatofibrosis.
A little bit around the central vein.
Well, that's a portal tract. That's a portal tract. That's a portal tract. That's a portal tract. The central veins are in where the fat is. And I'm not seeing any. That looks like a beautiful central vein. So there's no steatofibrosis. So this only has fatty change. Is that enough to call it fatty liver disease? There's no steatohepatitis and there's no steatofibrosis. Is that enough to call it fatty liver disease?
Yeah.
Yes. How much fat can be considered physiologic in the liver? 5%.
Less than 5%.
Yeah, less than, well, so, yeah. Less than 5%, which means just scattered droplets here or there. This is clearly more than that. So this is fatty liver disease. Alcoholic versus non-alcoholic. I can't tell by looking at it whether this is a drinker or a diabetic or someone with high cholesterol or with metabolic syndrome. So that's how I report it. Features of fatty liver disease, question mark, alcoholic versus non-alcoholic with 1, steatosis, mild to moderate, 2, steatohepatitis, absent, 3, steatofibrosis, absent.
So this question always comes up that we always read in textbooks that these are the features of fatty liver disease with alcoholic. So alcoholic fatty liver disease. And these are the histologic features often seen in non-alcoholic fatty liver disease. Well, I understand from whatever I feel that it doesn't make any sense on histology that we need to look at histologic features which should suggest alcoholic or not suggest alcoholic. What do you suggest?
Yeah, and if you look at how I wrote the chapters in Robbins, in Big Robbins, there's a section on alcoholic liver disease, and we just call it alcoholic liver disease, and there's a section on fatty liver disease associated with metabolic syndrome. In Baby Robbins, where I had to condense things down and make it much more efficient, I have a section on fatty liver disease, and I describe fatty liver disease generally, and then I describe which features suggest alcohol, which features suggest non-alcohol. But remember, while some things will tilt you towards alcohol, very prominent neutrophilic infiltrates, I mean really prominent, the kind you see sweeping through at low power. Really prominent ballooning with really coarse, thick Mallory bodies, not those stringy little granular ones I showed you here, but really coarse, thick ones like chewed up bubble gum. You think alcohol, but it may not be alcohol. It's more likely to be alcohol, but it may not be. It may simply be the way this patient develops non-alcoholic fatty liver disease. So there are no histologic features that determine definitively which one it is. It's the clinical history that does that. So that's why to be careful how you write your reports. But if I see something, once a month I see a case that comes labeled fatty liver disease, and clearly the clinician is thinking, because it's the major epidemic now, it's not alcoholic fatty liver disease, and I look at the biopsy and I go, oh, you better make sure this patient doesn't have a garbage can filled with empty vodka bottles. And that means sometimes talking to family members rather than the patient themselves. Sometimes the history comes out later. And that's really important because alcoholic liver disease can be treated far more easily than non-alcoholic fatty liver disease. Get people to lose weight and get their cholesterol and diabetes under control, not so easy. Stopping drinking is not easy either, but it's much more common than reversing non-alcoholic fatty liver disease, than reversing metabolic syndrome. So, case number 3.
So we have a 48-year-old female, increased ferritin, MRI suggesting iron deposition, rule out hemochromatosis.
Okay, so 48-year-old woman with increased ferritin, rule out hemochromatosis by imaging. What's the likelihood that a 48-year-old woman would have abundant iron stores showing up on MRI as hemochromatosis as the prominent major liver disease?
I'm not sure as far as, I mean, I'm saying...
Let's say it was a man.
I guess it's higher just because...
Why? That's the thing. Man versus woman.
Early.
Hmm?
Do it as early.
Why?
They don't have
After
menses.
menopausal.
Right, because you don't start accumulating iron until you stop depleting your iron stores with menstruation every month. So women don't start accumulating iron in their liver until they've gone through menopause. Men start accumulating iron early on in adolescence. And so everything is shifted later. So what's the likelihood of a 48-year-old woman having hemochromatosis as a primary liver disease? Not so much. Could they have some? Yes. But is it going to be driving their liver disease? Probably not. Increased ferritin is not an infrequent, now this came with MRI imaging saying that there was iron in the liver, but without that, increased ferritin is a very common thing you see in fatty liver disease. And a number of my liver biopsies now come with a history, elevated ferritin, abnormal LFTs, rule out fatty liver disease, rule out hemochromatosis. Because the clinicians have learned the ferritin goes up in fatty liver disease. Why? We don't know. It's an acute phase reactant, so that's part of it, but what the mechanism is, we don't know. But they often go together. So just because the ferritin knot is up doesn't mean hemochromatosis should be the first thing on your mind. We have an epidemic of fatty liver disease. In the United States, we can expect that 30 to 40% of Americans will have fatty liver disease, which is, what's the current population in the United States? It's like 300 million, so we're talking about 120 million people. So we called hepatitis C an epidemic. There were 4 million Americans with hepatitis C. Fatty liver disease, there may be like 120, 140 million people with fatty liver disease. So that's an epidemic. And if they have an elevated ferritin, it's more likely going to be that than it is hemochromatosis. So we pick up the H&E. And we see fat. Not dissimilar from the last biopsy, right? So mild to moderate steatosis. We look for steatohepatitis. At high power. No neutrophils again. And I'm not impressed by the steatohepatitis. A little bit of mononuclear infiltration in the portal tract, scant to mild. We see that with non-alcoholic fatty liver disease. I don't call that steatohepatitis without the other stuff. Maybe that will change in coming years, but right now, that's the standard. We're still looking for the classic features. So I don't think there's any steatohepatitis. Then we look at the trichrome for steatofibrosis. Oops, here's the cell tissue. And now we've got some pericellular fibrosis. Let's look for a cleaner area. So this is a central vein. The central vein is sclerotic. And we see wisps of collagen extending outwards around small clusters of hepatocytes and perisinusoidal deposition there. But it's pretty much all in zone 3. It's around the central vein. It stays confined to where the fat is. And there's the portal tract, totally uninvolved. Okay? So, features of fatty liver disease, question mark alcoholic versus non-alcoholic with mild steatosis, mild to moderate, steatohepatitis, absent, steatofibrosis, zone 3, pericellular fibrosis. So that's easy. We still have to question the iron thing. So we look at the iron. And there is iron. This is a Prussian blue stain. And notice that where there's fat, there's not much iron, and when there's no fat, there is iron. Why is that?
It can be primary as well as secondary.
That's not the question I'm asking. The iron is periportal. The fat is pericentral. So these are two diseases that develop different zonation issues. The reason the iron accumulates in zone 1 near the portal tract is the first hepatocytes, you're talking about having a circulating overload of iron. That iron comes into the liver through the hepatic vein, the hepatic artery and the portal vein. The first hepatocytes that are going to see it and bind it and store it are those right at the portal tract. When they get filled, it's the next row of hepatocytes that are going to pick it up. And when they get filled, it's the next row of hepatocytes. So iron starts near the portal tract and extends outward. Fat starts near the central vein and extends back towards the portal tract. So when you have iron, it actually complements the fatty change in this biopsy. Now there are two kinds of iron staining we're seeing here. One is coarsely granular iron, and that's the iron that we call hemosiderosis. The histologic feature, this is how I use the terminology, the histologic feature is hemosiderosis. The clinical condition or syndrome is hemochromatosis. So there is periportal hemosiderosis. And then there is also this pale blue blush to the tissue. That's ferritin. So both of those will register on MRI as iron. So this liver looked like it had a lot of iron. It has less than they probably expected. So this would be periportal iron. And there are different grading schemes for iron 1, 2, and 3, or 1, 2, 3, and 4. The simplest one is zone 1, 2, zone 2, 3, zone 3. This is clearly zone 1. It's mild, and so this is hemosiderosis, grade 1 of 3, question mark hereditary versus secondary hemochromatosis. She could be a carrier for the gene. She could be heterozygous for the gene. The reason she doesn't have a lot of iron, even if she's a homozygous carrier, is because she's 48. She just went through menopause or is still going through menopause. So she's just starting to accumulate. This is how much iron you might see in a 14-year-old boy. But maybe she's stopped menstruating, but she's continuing the iron supplements she always took her whole life and didn't think, oh, I'm no longer menstruating, I need to take iron pills. And maybe she's overloading herself with iron. She might not have a genetic thing. It could be secondary. So this gets two diagnoses. Okay.
So is there a histologic way to suggest that based on iron staining pattern, whether it is secondary or primary?
Oh, no. I mean, the old thing says, well, if you see biliary iron, it's more likely to be primary, hereditary hemochromatosis. But that's because you only see biliary iron when it's so severe, and the most severe iron overload is generally, was historically, hereditary. But now, that was before we were screening, that's before we were highly sensitive to the clinical issue of iron, so the biopsies that you usually saw were very advanced hemochromatosis with huge amounts of iron accumulation. And secondary would rarely get up to that. So hereditary seemed to have that as an indicator, but it's not. If you give enough iron, they'll both look exactly the same. So distribution does not tell you, but you have to think about the complexity of the gender, what genes might they be carrying or are they carrying, what possible reasons for secondary are there and how severe are they. A little bit of iron supplementation every month, with vitamins is way different than having thalassemia and getting chronic transfusions.
So in early stage of hemosiderosis in the liver, the iron accumulating in the Kupffer cell versus iron accumulating in the hepatocyte, so you can suggest which way it goes. Is there a practical?
Well, okay. If you see only in the reticuloendothelial cells, so Kupffer cells and endothelial cells, if you only see that, that's secondary. But if you have hemochromatosis with iron accumulation, some of those hepatocytes are going to die, and some of that iron is going to go into the reticuloendothelial system. So if I see reticuloendothelial iron and hepatocytes, to me it's still in the hemochromatosis area. Primary versus secondary, I can't tell. If it's just in the reticuloendothelial system, then what I'm thinking about much more is hemolysis. And that's a little bit more typical. And in part because with hemolysis, you get a wave of iron coming through. The reticuloendothelial system will pick that up. But hepatocytes aren't chronically storing and accumulating iron in those cases because you don't chronically have hemolysis, most people. So that's how I would distinguish it. But if there's, so reticuloendothelial by itself, I'm thinking hemolysis or some other secondary thing. But hemolysis is the big one. If I see iron, the presence of reticuloendothelial, if I see hepatocyte storage, the presence or absence of reticuloendothelial iron doesn't dissuade me. Where you see more reticuloendothelial iron is, let's say, a patient with hemochromatosis who also has fatty liver disease or who also has hep C. So you have iron-storing hepatocytes that are being injured by some other disease, and they're going to release that iron, and the local endothelial cells and macrophages will pick it up.
So how is iron related to fatty liver disease? You see iron accumulation in fatty liver disease?
No, you see ferritin accumulation, and we don't know why. It may be because it's a acute phase reactant. No, not hepcidin. That's a whole other thing we're not going to discuss today because we don't even have time for the fourth case. So we will continue next month with non-fatty liver disease common problems. Okay? Thank you very much.
Thank you. Thank you. Thanks everybody who has joined us on Periscope and Twitter. Thanks a lot.